Thank you so much for having me. Can you guys hear me okay in the back? Someone? Okay. So please interrupt me and ask questions. That would be really nice. So I am a neuroscientist and a pharmacologist, and I use rodent models to study how experience changes the brain. And one of the experiences I'm interested in is how experiences with potentially addictive drugs like cocaine change the brain, and what changes produce drug addiction. And so we all experience drugs in our daily lives, right? So I start my morning with a big cup of coffee. It's got caffeine in it. Caffeine's a psychoactive agent, and I drink it, it gets absorbed in my stomach into my bloodstream, travels to my brain, where it makes me feel less tired and a little bit more alert, right? We also use drugs in modern medicine. Without drugs, we wouldn't be able to treat pain. We wouldn't be able to do surgeries. We wouldn't be able to treat depression or anxiety. So drugs are a really important aspect of modern society, but they can have an abuse potential. And so what I want to talk to you about is how we can think about the abuse potential of drugs and what factors are really important. And so not all routes of administration are equivalent. So factors that can influence how likely a drug is to be abused is how fast it's getting to the brain, how much of the drug is there, and how frequently the drug is being used or experienced. And so I'm going to talk for a bit about my favorite thing in the world, the brain. Let's see, is that? This is an MRI of a human brain. These are some beautiful images. This is a pyramidal neuron. You can see it has a cell body and all of these long processes that are called dendrites. Over here, these are some images of a mouse brain. So this is the cortex, which is the equivalent of the cortex in the human. You can see all the cell bodies in these dendrites, another cell body layer over here. This is hippocampus, which is another different brain region, all the cell bodies and all of these little dendrites that are extending out. And all of those dendrites are getting inputs from other parts of the brain. There's millions of synapses on each of these neurons, and they're integrating all of this different information, so sensory information. You're hearing me. You're processing my words, right? And you're thinking about what those words mean, and that's all happening in your brain. And drugs, are potentially addictive drugs, are acting on these neural circuits, and they're acting on them to produce their desired effects. So when I have caffeine, I want to have help me be a little bit more awake, a little bit more alert, right? But it also has other effects that might be less desirable. So I'm going to talk mostly about psychostimulants, which are a large class of diverse compounds. The major ones are the amphetamines and related compounds and cocaine. And so they're called psychostimulants because they stimulate and increase alertness and arousal. They also stimulate motor activity. And I'll talk a little bit more about what I mean by that in a minute. They're used both for medical purposes as well as for non-medical purposes. So some of the most commonly abused drugs today are amphetamines. I'm going to focus on cocaine, but but you'll see that there's common themes to what makes a drug more or less likely to be abused. So cocaine is a naturally occurring compound. It exists in nature. It comes from the coca leaf. And it was very common and still is common for cultures in South America to chew the coca leaf. And when you chew it, there's a very small concentration of cocaine in the leaves, and it gets into the circulation really slowly. It's also broken down and not absorbed actually very well in the environment of the mouth. So what you get are really mild stimulant properties, more like a strong coffee. But if you isolate cocaine from the coca leaf, you are concentrating it, right? And now you have a powder that can be ingested much more rapidly. So you see in movies, right, people are snorting cocaine. You can also use this form to be injected, right? So now the route of administration is totally different. You're putting the drug directly into the vein. Similarly, this is a picture of freebase cocaine. These all contain the same structural compound. They all contain cocaine, but at different concentrations, and they can all be administered through different routes. So the freebase cocaine can be smoked so that it can enter the bloodstream very quickly. Another form of this is crack cocaine, which is a highly addictive substance. And so cocaine, like I said, can produce stimulant effects. It can increase alertness and arousal. It also is a sympathomimetic. So it can mimic the activation of the sympathetic nervous system. So it increases heart rate, it increases alertness in general, and it also has local anesthetic properties. So cocaine can numb things. It blocks gated sodium channels to do this, so the signals don't get through anymore. And so when cocaine was first isolated from the coca leaf, they put it in all kinds of things because it's great. It makes you feel invigorated, makes you feel better, gives you this sense of arousal. So they put it in cocaine, in Coca-Cola for a while, wine, even in dandruff shampoo. Because remember, there's no FDA, right? So you can put things in, see what happens. And it was in Coca-Cola until about 1903. It had about 60 milligrams. But again, you're drinking this substance. It's getting absorbed pretty slowly. So you're probably going to get a little bit of buzz off of this. And it's going to depend on how much of it you drink and how frequently and how fast, right? There's also some other aspects here. This is mixing drugs, right? Putting cocaine into wine. Now you have drugs and alcohol. That's not the same as the drug on its own, right? Because you're going to have mixed effects here. This also was in these toothache drops that people would give to children. This actually makes sense. I told you it causes numbing, right? So that's a really useful thing. It's going to relieve the toothache, but it has this unwanted side effect of stimulating arousal, right? So the kids are going to be a little bit more alert than maybe you want them to be, right? So not the ideal way to solve a toothache. But there's logic to that, right? That's what I sound like. I'll hear that. So like I said, the route of drug administration really matters, right? So this is plasma concentrations of cocaine. So how much cocaine is getting into the blood. And down here, this is the self-reported high from users. So how euphoric, how much of a high does this give you? And you can see that you get pretty strong ratings for smoked and intravenous cocaine, but kind of mild ratings for the snorted cocaine. When you have intravenous drug, you get this really big ramp up of cocaine into the brain, and then the effects go away rather quickly as well, right? Whereas if you have the oral administration through the mouth, you have this much more gradual rise in concentration of drug, and it also doesn't peak as much because the drug's also being removed from the system at the same time, right? So drugs that get into the brain really fast are more likely to produce this type of euphoria or high than when drugs get into the brain really slowly, particularly in the case of psychostimulants here. All right. So the effects of the drug are going to differ based on this route of administration. So you get more of a high when you have smoked or intravenous use versus slow absorption through oral. It also depends on the dose. So moderate to mild, doses of cocaine increase mood, they heighten your energy, they can create sleep disturbances, but you can get much stronger effects to the degree of total insomnia, so people staying up for days. This is a bit more common when we think of amphetamines. You get motor excitement and talkativeness. That also gets a bit stronger. You get these compulsive motor stereotypies, or punding. So the classic example of somebody on cocaine is they'll do really complicated things, like take apart a watch and put it back together, and then take it apart again, and then put it back together. They just get stuck in this very complicated pattern of motor behavior. And I'm going to show you an example of that in a few slides from one of my rats. But you can also get some things that give you opposite effects. So for example, you can get increased sexual interest with lower doses, but you can get decreased sexual interest with higher doses. You can also get inflated self-esteem, but all the way to the extreme of delusions of grandeur. I can fly type stuff. No, you cannot fly. So the dose matters, the route of administration matters. There are medical uses for both cocaine and amphetamine. So Adderall is DL-amphetamine. Disoxin is methamphetamine. Methylphenidate is very similar to cocaine. And we use these to treat ADHD and narcolepsy. They're really effective at treating ADHD and narcolepsy. And this is really low doses that are taken orally. So when they're taken as medically prescribed, they don't have that, they're not likely to cause addiction, but they do have an abuse potential. So if you take them not as prescribed, if people decide to snort them or take more pills than they're supposed to, or maybe give a pill to somebody who doesn't have a prescription, who doesn't have ADHD, right? Those are types of behaviors that we see are more likely to produce addiction because you're changing the amount of drug that's getting to the brain. If you're snorting it, it's getting to the brain faster. And so they have the biggest problem with these medications is diversion, people giving them to their friends. It's actually a federal offense to give any of your prescription drugs to somebody else. That's not legal. You're not supposed to do that. And so they've tried to combat this a bit by making formulations that have slower release so that you can't take 3 or 4 of them at once to get a high. And we're still kind of waiting to see, that's fairly recent, to see how effective that is in stemming this problem, which is a problem in mostly high schools and the colleges as well. All right, so I said drugs are acting in the brain, so we should probably learn a little bit about how they do these things in the brain. So here I have a picture of a chemical synapse, so a connection between 2 brain cells. This is a cartoon, the same thing. So on this side is the presynaptic terminal, so this is one cell, and it has neurotransmitter, which is a chemical signal in these vesicles, and that it can release and interact with this other cell, which can receive the signal. So neurotransmitters are chemical signals in our brain. They're how our brain cells communicate to each other. And the two ones I want to talk to you guys about today are dopamine, which modulates or tunes activity. So it doesn't necessarily excite or inhibit a cell. It tunes activity of that cell. And it's really important for reward and motivation. So things that make you happy, things that you need to exert a bit of effort to do. So, okay, I got to get myself out of bed to go do this running at the track this morning with my team, right? That takes motivation. You need your dopamine system on board to help you do that. Another type of transmitter is glutamate. And glutamate is the main excitatory transmitter in the brain. So it activates neurons. It makes them fire and has them send signals to each other. And glutamate is really involved, it's involved in many processes in the brain, but the context we know the most about it in is learning and memory. So tomorrow you're going to remember that you were here, right? At least you'll remember you're here if you won't remember anything else, right? Well, that means your brain's different. That information that you were here, that you saw so-and-so, that you sat in that seat is in your brain. It's in that biology, and it's because the biology changed a little bit. And one of the things that's important for those types of changes is changes in glutamate transmission. And so not all systems in your brain are affected equally by potentially addictive drugs. It turns out that there's one system in particular that's most affected, and we think of this as the brain's reward system. So this is a common system that really evolved to help us find food, to help us find a mate so we can reproduce, and drugs act on this system. So on the left here, this is a rat brain, and the part of this circuit are the dopamine cell bodies that live in the VTA. So these neurons in the VTA send projections or connections to other neurons in this other region over here called the striatum. In the human brain, it's the same. You have dopamine cells in the VTA that send projections up to your striatum. You also have excitatory signals, this glutamate transmitter, from a bunch of different regions, particularly the prefrontal cortex, that also sends projections to the striatum. And it's the same in the human. So here is the prefrontal cortex in the human. It's receiving dopamine inputs, but it's also sending these excitatory glutamate inputs back to the striatum. And so the striatum is integrating all of the information. You know, oh, I'm cozy in my bed, but I'm kind of hungry. Should I get up and should I go get food? You need your striatum to integrate all the possibilities and the interactions to help you decide to go make that action, to go get up and go downstairs to the refrigerator. And so drugs are acting on these systems that already exist in our brain. And so potentially addictive drugs have one thing in common. Well, they have a bunch of things in common, but one of the main things they have in common is that they increase dopamine levels in the brain. So this transmitter that signals something is rewarding or motivationally significant, basically, they all do it. Amphetamine, the opiates, which opiates are sedatives, right? They treat pain and they also make people sleepy. They have very different effects, but they also have a very high potential for being abused. So these are data from rats, and it's showing you, so all of these increasing lines, this is after ethanol, so the compound, it's active in alcohol. You get a nice increase in dopamine. You get a nice big increase in this other part of the striatum. This is after amphetamine, nice big increase in dopamine. Over here, morphine, again, nice increase in dopamine. So all of these drugs are causing an increase in dopamine in these striatal regions. And the way that they do this is they can actually measure the amount of transmitter that's in the brain of awake animals. So this is in an intact, or mostly intact system. All right, so how do drugs do this? So they all do this by different mechanisms. So I'm going to tell you a bit about cocaine. So I said that you have one neuron here that's going to send a chemical signal to this other neuron here, right? So it's going to send this release this transmitter dopamine, and it's going to bind to those receptors. Well, you need to stop the signal, right? So the way that the brain normally stops a signal, which is cartooned here, is by this thing called the dopamine transporter. It's basically a little vacuum that's going to pull the dopamine out of the synapse, and that's going to stop the signal. Well, cocaine just blocks that dopamine transporter, so that when dopamine is released by the brain in a normal fashion, you just get more dopamine in that synapse, in that space where the neurons are communicating. And so that's another, this is another example of that here. You get this nice big increase in dopamine. So amphetamine also works at the dopamine transporter, but it works a bit differently. It actually reverses the dopamine transporter and causes the vacuum to instead dump dopamine out into the synapse. So I talked a little bit about the effects of these psychostimulant drugs in people, but what about in rodents? Because that's what we use to study them. So they also activate locomotion, so moving around, in rodents. So you can see here, these two guys, they both have had cocaine. This guy's had a lower dose than this guy. You can see that he's darting around. He's making all these focused movements, these focused sniffing movements. That's what we call a focused stereotypy. And then he kind of darts over to the other corner, right? So these are typical locomotor responses. And we can look at the strength of these locomotor responses as an indication of changes that have happened in the brain. All right, so what do you guys think would happen if we deleted the dopamine transporter? What would happen to dopamine? What would happen to that behavior? So some people did this. Some people, namely Sarah Jones and Mark Carone, at Howard Hughes and at Duke. So they made a knockout mouse genetically. And so they removed the dopamine transporter from the mouse. And so look really closely. I think it's playing. Yeah. There's going to be 3 mice. And see if you can spot which mouse doesn't have the dopamine transporter. It's really hard, right? Yeah, not the white one. The white one's okay. The brown one's okay. He looks like he's had drug. Right? He looks like he's had a stimulant because he's running around a lot, right? So when you remove that dopamine transporter, you get more dopamine in the synapse because now the brain has no way of taking it out, right? And you also get a much stronger locomotor response. So that animal already looks like he's on a psychostimulant. If I give him a psychostimulant, I'm not going to be able to tell the difference, right? All right, so talked a little bit about common brain systems that that mediate drug addiction. So these dopamine projections from the VTA, the dopamine cell bodies to the striatum, and that all drugs that are potentially addictive have this ability to increase dopamine levels. But the route of drug administration really matters. So the same drug given orally can have much more mild effects, much less potential for abuse than that same drug given intravenously. And so the route of drug administration and the rapidity with which it gets to the brain really matters, as well as the frequency of use, how many pills people are taking in a day, things like that. And so I really want to emphasize that drugs are not producing a unique effect, right? Cocaine isn't making something that's never happened to the brain happen before. It's increasing that normal, or what we call endogenous signal, to a level that may or may not normally be there, right, depending on the dose. All right, so I'm going to talk a little bit about drug addiction because I think it's a really important problem in society, and it's also a really fascinating topic. So drug addiction is the result of changes in the biological function of the brain, right? And this is due to repeated exposure. So what I was talking about so far was just what are the initial effects. If I give 1 dose of drug, what's the effect, right? 1 dose of drug does not an addict make, right? It's repeated exposure. And so all drugs that are abused and people can be addicted to, nicotine, opiates, THC, marijuana, they all change the brain. And it's those changes that produce drug addiction. And so the way we diagnose addiction in people is with the DSM, which is made by the American Psychiatric Association. And so they don't use the word addiction. It's substance abuse and substance dependence. And these two categories are defined largely socially. So on the substance abuse side, does drugs interfere with your social function, endangers health? You have persistence of use despite negative consequences. So maybe someone got in trouble with the cops, right, because they have an illegal substance. Whereas substance dependence has all those same exact qualities, but they throw in the idea of the person experiences physical withdrawal or tolerance. And tolerance simply means they need more of the drug to achieve the same effect or the same high. And there's a sense of a loss of control. I want to stop, or I didn't want to drink more, or I didn't intend to have any drug that night, but I did anyways. And that loss of control and that inability to limit drug use, even despite a lot of very serious negative consequences, like going to jail, having your children taken from you, that is kind of what we classically think of as addiction. Also, in the research field, we think of relapse as well. So people who are drug addicts, their problem is they can't stop taking drug. Even if they stop for a little while, they tend to relapse. And so in basic sciences, when we study drug addiction, we also tend to study relapse, even though it's not really in the diagnostic criteria. So, like I said at the start, I study rats. This is one of my rats. He has this little port that you can see coming out of the back of his neck. So we did a surgery on him where we put a tubing into his jugular vein, and that tubing runs underneath his skin where you can't see it, and it just comes out his little back port right there. And he's hooked up to this tether and a syringe that you can't see. And when he pokes his nose in that little hole, he can get an infusion, an intravenous infusion of cocaine or any other drug we choose to study. And so we're looking at a route of administration that's relevant to drug addiction, right? So now we're talking about intravenous cocaine use. And we can ask the rat questions, like, how hard are you willing to work to get an infusion of cocaine? So if you ask him to press once for cocaine, press once. What if I ask you to press 200 times before you get an infusion of cocaine? So you can see the price or the willingness, how willing they are to work to get that infusion of cocaine. And so it turns out rodents will self-administer almost any drug that people will self-administer. So ethanol, ecstasy, Ritalin, morphine, marijuana, but not all drugs. So aspirin. We don't have a big drug abuse problem for aspirin, right? Rodents won't self-administer aspirin. But using a drug is not really drug addiction, right? Lots of people drink, right? That's fine. You can have a glass of wine. But that's not in and of itself enough to constitute addiction. You also have experimental use. Maybe somebody tried a drug once or twice, and that was it. That's not really addiction. You also have circumstantial use. So if someone's hospitalized, they might be on a morphine drip. They're going to be exposed intravenously to morphine, but then once they're over their hospitalization, that's it, right? They're not going to be using drug. So my animals that are taking drugs in my experimental situation, that's not in and of itself quite getting us there, right? Because we want to model these compulsive-like behaviors, right? So a lot of work has been done in the field, and we're still trying to develop better models, but these are pretty darn good. So it turns out if you give animals limited access to this self-administration procedure, so just 1-2 hours a day, you get drug-taking behavior, but not behaviors that really fit in these categories of addiction. Whereas if you give them this extended access, you start to see the development of addiction-like behaviors, right? The consequences, the negative outcome consequences for rats are very different than for humans, right? So we're trying to model some aspects as best we can in rodents. All right, so I'm going to show you some data where we let animals self-administer cocaine, so they get to nose poke and give themselves as many infusions of cocaine as they would like, and we gave them either limited access or extended access. And so you can see that. So what I'm trying to show you here is extended access animals escalate their drug intake. This is a feature of drug addiction. People keep increasing their dose of drug. And so here, this is just how many infusions they're taking in the first hour of their self-administration sessions. And so the guys that have had this longer exposure escalate their drug intake. Whereas the guys that have had limited exposure, they stay pretty steady. Their intake is pretty consistent over days. And so this is consistent with the idea of the extended access being a better model for drug addiction. All right, so then we left them drug-free for 2 months. We just put them back in their home cages. They went about their happy business. And we asked them about their cocaine-seeking behavior. So now I took the cocaine away. They don't get any infusions of cocaine. They nose poke, and they don't get cocaine. And you can see that the guys that had the limited access, they poke for a little while. They respond, but they eventually stop. Whereas the guys with the extended access, they continue to respond, even though they're not getting any cocaine. So they have this kind of enhanced drug-seeking behavior. And so we asked, do these different drug experiences produce different effects on spine density? So spines are those places on the neurons where the connections are being made. So this is a picture of a neuron in the striatum. So there's its cell body with all these dendrites. And every little one of these protrusions there is a spine. And on these spines are multiple synapses, so multiple points of connection. And you have both dopamine connections and glutamate connections. Remember that striatum is integrating these signals and participating in motivating behavior towards a goal, towards something that is wanted. And so spines are really dynamic. They change with normal learning and memory processes. So the number of spines, the number of dendrites, the number of connections between spines, they all change as a function of experience. And we think that a large part of learning is this type of plasticity in spines. And you can also have changes in the number and function of the receptors, right? So the one cell is sending that presynaptic signal. The other cell is receiving it mostly by receptors on that postsynaptic side. So if you change the number of receptors, if you increase them, then the signal is going to be stronger. It's going to be better able to get through. If you decrease them, that signal is going to be weaker. It's going to be less able to get through. So we wanted to know what happens to spines in addicted rats. So what we did was we let animals self-administer drug for either those 1 or 6 hours. And then we used a technique called Golgi staining, and we actually measured, we quantified how many spines there were per a given unit length of dendrite. And so after that limited access, which produces drug taking, you get more spines than in the control animals that never got any cocaine. But in the addicted animals, you got an even greater increase in this spine density, specifically in a part of the striatum that's involved in reward-seeking behaviors. So you don't see these types of changes just everywhere globally. So we also looked in the prefrontal cortex. So that's the cortical regions that are sending that glutamate signal and that are involved in decision-making and executive function. And so here are the controls that were self-administering saline, and then the guys that got the limited or extended access cocaine. So both of these groups were experienced with cocaine, but you can see they don't differ, right? So just experiencing cocaine increased the spine density in this particular brain region, but it didn't differ by this extended or limited access, by this addicted-like behavior versus this drug-taking behavior. In another region of cortex, there were no changes at all. So the changes that we're seeing are selective to the areas that are involved. Well, that's how we know these areas are more likely to be involved in the drug addiction process. And so this type of cocaine self-administration in our rodents is increasing spine density. And work from a number of labs, including Marina Wolf and Peter Kalivas, Terry Robinson's done a lot of this work as well, has shown that you also have increases in the number of dopamine and glutamate synapses and neurotransmission mediated by these glutamate signals. And you also have increases in glutamate receptor expression. So both sides are changing, the synaptic connections coming in and the receptors that are present. And it also turns out that if you block glutamate receptors, so the receptors of that signal, just in the nucleus accumbens, so if we put the drug straight into the nucleus accumbens in an animal that's awake and behaving and has self-administration experience, you can block that enhanced drug-seeking behavior. So we're using that type of information to try to treat drug addiction, right? So there's the one side of how do we prevent it from happening to begin with, but then there's the other side. Once these changes have happened, how do we block that behavior? How do we prevent these changes from influencing behavior? And so currently approved treatments in the US are predominantly rehab and counseling. People get 6 to 8 weeks of treatment, after which they have very little follow-up. And the numbers are a bit depressing. The propensity to relapse within the first 6 to 8 weeks after someone leaves rehab is between 75 to 80%, sometimes worse, depending, because there's really no a support system. That's kind of a different conversation we could talk about if you like. So there's a lot of approaches under development to try to address these changes in brain function. And so one idea is replacement therapy. This hasn't caught on so much for psychostimulants, but certainly for the opioids, methadone is really effective at helping recovering addicts stay functional. People can go to their jobs, they can work. For nicotine, one of the leading approaches is the patch, right? So it's a replacement therapy. Don't smoke your drug, we'll wean you off it really slowly. For that, because of the data I was telling you about, people are looking into drugs that specifically block the glutamate receptor. Can this dampen the drug-seeking behavior? And people are also interested in looking at drugs that block the actions of cocaine. So if someone's trying to remain abstinent and they relapse, they take a drug. If they have another drug in their system that prevents the actions of cocaine, then the relapse should either be ineffective or not as bad. And so some of the approaches are a drug called cocaine esterase, which Dr. Jim Woods in my department has been working on for a number of years. So it's basically an enzyme that if you have it in the circulation, as soon as cocaine gets in the circulation, the enzyme chews it up. So it's as though the drug wasn't there. There's another approach, which is people are looking at for amphetamine. This is by another researcher in my department, Peggy Negi. That prevents the ability of amphetamine to reverse the dopamine transporter. And the same idea, someone relapses and takes drug, they won't get the high, they won't get that effect, and that will help them on their recovery is the logic. And people have also talked about trying to develop antibodies. It's the same kind of concept that if you take the drug, then the antibodies will bind it up and you won't relapse. It'll be a preventative. All right, so I'm going to wrap it up for you guys so that we have enough time for questions. But what I hope you guys have learned today is that the dose and the route of drug administration really changes the subjective drug effects as well as their potential for, as well as their abuse potential. All potentially addictive substances have this common ability to activate these reward circuits in the brain, the circuits that are supposed to help us direct our behavior towards food, towards a mate, towards sex, and towards things we enjoy doing. Drugs basically make the brain, these systems, hyper-responsive to things that we've learned about with drugs. So one of the most common reasons for relapse is people go back to some place they used to take a drug, right? Or they go, so I mean, it's really common if you just think about smokers. People are like, oh, I always smoked in my car, or I always smoke, with my coffee, right? Those are cues because they've learned those associations, and those cues often trigger relapse. So part of that is that these systems are hyper-responsive now to those cues. And these changes are very long-lasting. So in my animals, I was showing you 2 months. Rats only live for 2 or 3 years. So 2 months in a rat's life is a really long time. And people who are recovering addicts really do have to address that for the majority or the rest of their lives. And in particular, with cocaine, I showed you guys that it increases the number of synapses in the striatum, in this particular region of the brain. And it also increases that excitatory drive, that glutamate system. All right, so with that, I want to acknowledge people who did a lot of the work that I was talking about. So Marina Wolf at Rosalind Franklin University in North Chicago is one of the forerunners of looking at excitatory transmission and how that's changed by drugs of abuse. Terry Robinson's group was one of the first to show that you get these increases in spine density as a function of drug exposure. And Mickey Marinelli has done a lot of work looking at adolescent drug exposure and also how drugs change the dopamine system. And they also were kind enough to share some of their slides with me as well. And I also want to just say hi to my lab members who helped me get the business done. So I'll take any questions you guys have.
Before you ask a question, those who okay. Before you ask a question, state your name so that everyone looking on and here would know who you are. We have a number of professors too, so just tell us, your name and probably what you do.
Hello, my name's Noah.
Noah?
I was wondering what happened to the mouse that had the receptors or the protein in its brain removed so that it couldn't take it up.
The dopamine transporter knockout?
Right.
Yeah, so do you mean, well, so what do you mean by what happens to him? So,
As in how long did it live or
I see.
what was the result of it not having it?
Right. So that locomotor behavior that you guys saw, he was running around like crazy. Once he explores that environment, he will actually settle down again. So it's not a perpetual constant. He can stop and he can eat, he can do other things. I don't know how long they live, but that's a good question. But I don't believe that it produced any overt like toxicity. Doesn't.
My name is Gideon. My question is, how long did it take for the mouse to become addicted? Like, was there a timeline to how long it took to be addicted to the drug?
So that's a really good question. So the answer really is it depends. So empirically, what we did was we gave them 6 hours of access for 10 days. And that was enough to trigger these changes. Other people have used a different approach where they give them limited access for weeks or months. And that also can produce addiction-like behaviors. And so the idea is that there is a certain amount of drug that's needed. You have to have a certain amount of drug exposure to be a drug addict. But what that magic number is, or what that might be for any one person, we don't know. And it's really going to depend a lot on the person and their experience.
Jasmine, what was the significance, or what does it mean when you say that the spinal density was increased, or it increased the density? What does that mean?
So it means that there are more connections into that brain region. And so the idea is that those connections are now stronger, but they've been strengthened by this drug experience. And so that is what is kind of invigorating or driving the behavior more towards drugs than something else.
Hi, my name is Roseanne. 2 questions. One, you were talking about the drug therapies that you guys are looking into, and you spoke of cocaine esterase. When would something like that be administered?
So the idea is that it might be administered to somebody who's leaving rehab, right? So somebody who has gone through a program, their detox, they've gone through their rehabilitation, and then this would be on board to kind of help them as a backup, so that they would, if they relapsed, then this drug would kind of prevent it from being as bad, basically.
That's something they would have in their system.
So it's something they would have in their system, yeah. It would kind of prevent them from being able to get high.
Okay. And my second question, towards the beginning of your presentation, you spoke of methamphetamines and how they were trying to modify it so people wouldn't share them with their friends and stuff if they had prescriptions.
For the ADHD drugs, yeah.
Yeah. So do you have any idea what modifications they want to make to those drugs so that they have a slower release?
I don't know the chemistry of how they make them slow release. I think it's also the tablets as well. Okay. So they're trying to, when people are using ADHD drugs as prescribed, that's not going to lead to an addiction like addiction behaviors. But they're trying to limit people's ability to take a bunch of them all at once to get a high off of them. Yeah.
Hi, my name is Swanika Choi. I have a couple questions, actually. The first is when did everyone, I know that you have a regular amount of dopamine release just by basic activities that make you happy. So I was wondering if they ever thought during rehab if they would help them, train them to do activities that might increase dopamine in their system to kind of like get them to wean off of drugs, and then like increase the length of how long rehab is, and then kind of like have routine checkups on you, kind of training yourself to
something new.
Something new.
those are very reasonable approaches. I think we don't biologically know exactly what the best way to do that would be, but certainly follow-up treatment and keeping people in rehab longer or giving them longer follow-ups after would be somewhat helpful. And we don't really know. We do have evidence that the changes in an addict's brain can recover, but it seems like it takes a very long time, so years.
Okay. And my second question doesn't really have to do with the drug, but you were saying that you need dopamine or the surges in the what's the part of the brain you called it?
The cortex, prefrontal cortex?
Yeah, that you need that for like motivation if you want to get up to go get food or you have to work out. So would you say that someone being lazy or procrastination is a lack of like dopamine?
I think that might be an oversimplification.
Hi, my name is Betsy. I have a question about the cocaine esters and the other two that you mentioned, but I don't remember the name. Have you tried those on your animals?
So the cocaine esterase work, Jim Woods has published papers, and if you go to the NIDA website, there's some articles as well about that. There's a number of published papers on the mechanism of action and how much cocaine esterase to how much drug. That's out there in the literature.
So if a person needs to take that, would they have to take it daily?
What the hope is, so this has not yet been implemented in people as far as I know, but the hope is that they would have a slow release type of thing, so something that would be injected under the skin and that would be for many months, something like that.
Thank you.
Hi, my name is Songjun. Earlier you said those drugs actually prevent the dopamine reabsorptions. So about how long do they remain within the cell without getting degraded or reabsorbed?
That's a really important question. So it depends on the route of administration, but for cocaine, the half-life can be half an hour to an hour and a half. So the half-life is the time to half of the initial concentration. And that varies by route of administration and by drug. Yeah.
Anybody on this side?
There. I feel like we should get up and make a line.
Hi, my name's Clementine, and I'd like to know whether an individual's genetic makeup affects whether one person will be more prone to addiction as opposed to another.
This is a very big area of research, and the short answer is yes, though it depends. So there are certain polymorphisms in the dopamine transporter that they have noticed. They find more in people who are drug addicts than not, but it's not 100%. If you have X, then you will experience Y. So there is a strong genetic component. There's a strong personality component to this as well. So people that are thrill seekers, it sounds almost silly. Well, people that want to experiment with drugs to get high are more likely to end up being drug addicts. But that is part of, it's a trait, it's a psychological trait that's a result of your biology. So there are interactions between these two systems.
Hi, I'm Jason Grellman. I was wondering how the spine counts. Does it affect the susceptibility to a drug, or what does that affect?
So those are all changes after drug exposure. So not necessarily, so the spine changes are not affecting susceptibility. They're a result of that drug exposure. So the drug is causing those changes, and we think those changes are important for those addiction-like behaviors.
Okay, and then I was also wondering, how do you synthesize your own cocaine, or how do you...
Right, okay, so we don't synthesize cocaine, right? We get it from coca leaves. And so actually, I get my cocaine a lot of my work throughout the years has been funded and sponsored by the National Institutes of Drug Abuse, Drug Addiction. And they supply the cocaine to me, and they actually get it from confiscated cocaine. And they purify it, clean it up, because something we didn't talk about, street drugs are not pharmacological grade agents. They are not. That's a totally other can of worms when someone's synthesizing compounds in their kitchen sink. When cocaine on the street is usually cut with something, you don't get pure cocaine. So we get it from NIDA, and by what I understand, they confiscate it, they purify it, and then we can use it.
Hello, my name is Seth, and I was wondering how the drug addiction, how does it affect the release and production of the body's natural dopamine?
That's a really good question. So people have been researching what drugs do to dopamine. So how, if you have repeated drug exposure, what does that do to the dopamine signal for a very long time? The most correct answer would be really, really complicated because we're still kind of working it out. So what it seems like it actually does is it kind of decreases that signal over time in the normal, in the absence of drug. But you get an overshoot when drug is re-exposed. So again, it kind of depends. Your brain is incredibly plastic. And so with drug in the system, the brain is in one state. With repeated drug, the brain adapts to that repeated activation. And then when you suddenly take the drug away, it adapts to it again. So the dopamine signal changes over time. We think that it decreases in some aspects, but in other aspects, you get an overshoot, an increased response.
Hi.
Hello.
My name is Heaven. I don't know if this was part of your experiment, but have you tried reproducing your rat that has been addicted? And then what kind of effect this addictive drugs have long-lasting effect? What kind of effect it has
So is that effect passed down? Is there an epigenetic phenomenon? So I have not done that. And so people do look at these types of things. Some things do have epigenetic phenomena, and I cannot think of an explicit answer to accurately to tell you 100% which way it is. But I do know people are looking at those types of effects. But to my knowledge, with the complex of addiction, that complex behavior, I don't think that's been demonstrated. I don't think anyone's shown that.
Hi.
Hello. Okay. Move the mic a bit, because I can hear you, but yeah.
Okay. So you were talking about the increase of spines with, overuse. I wanted to know, is there any work being done on possibly reducing spines, or is that possible for those spines to reduce?
Yeah. So there's some lovely studies where they were able to reverse some of those changes, and you can affect and reverse some of those behaviors.
So is that something that's possible for rehabilitation, or is it being used?
The hope is that it will be.
Okay.
So the level of the advantage to using rats is that we can ask these questions where we can look at spine density, right? In people, what we look at is functional MRI, which is the current cutting edge technology, right? But that doesn't get us down to these types of levels. So you can look at activation in the brain, and the activation in response to drug paraphernalia in drug addicts, recovering addicts, is really big in these striatal regions. So it's very consistent. And there have been some post-mortem studies on addicts where they found increases in glutamate receptor expression. So we think that we are mirroring what we see in people.
Hi, it's Gideon again.
Hello, Gideon again.
We talked about the addiction process, but do you guys do a detox process for these mice? For
the rats and the mice, we leave them in their. We don't do a detox. We just leave them in their home cages on their own for with their buddies and free food and free water, and then we can ask questions later. So the longest periods, let's see, 45, 65 days after drugs. So you still see really long-lasting changes.
Hi, my name is Andrew. I was just wondering if cocaine esterase has been used to treat overdose.
They have thought about it. So cocaine esterase has not yet been used to treat anyone. Hopefully it will be used to treat people. It seems like it would be really good. Theoretically, that should work, and I'm not sure of the limitations of how much compound you can have on hand to actually effectively do that. But that's a reasonable idea.
I wanted to know, during your experiments, is there a specific person that handles the cocaine? Because I know you're working with, are you working with students just to make sure no one gets tempted or,
Yeah. Yeah, so these are controlled substances. So all of the drugs we're talking about today are controlled substances. Some of them are what we call Schedule II, which means that they have some medical use. So like amphetamine, it has a legitimate medical use. Whereas in the US, something like marijuana is still Schedule I, has no legitimate medical use as far as the federal government is concerned. And so there's really tight regulations on that. And so we have a drug safe. I have a Schedule II license that the DEA that I had to apply to for the DEA, had to go through a background check, get vetted. I am legally responsible for all the drugs in my lab. And so we have protocols in place. So like undergrads don't know the combo to the safe. Undergrads don't weigh out cocaine. I weigh out cocaine. And how much do you need for what experiment? Where's the data that goes with it? Yeah. So there's a very elaborate tracking system because it's important to keep track of these things.
Yeah, over here, my name's Dave, and I just have a question. I realize this is not part of your study, but do you have any inclination or sense about the relative addictiveness of some of these drugs? One of the things I've claimed before, and I'd just like to know how accurate I am, I've claimed that nicotine is among the most addictive of the drugs because of its difficulty to get off. From your opinion, and I know you don't do the studies, how accurate is that? And is there a drug that you would fear almost in terms of being addicted to?
Well, so I think it's very accurate to say nicotine is a highly addictive substance, right? And especially because how is it taken? It's smoked. Nobody, so you can go buy Nicorette gum in the pharmacy. Nobody is going home. Nobody's taking Nicorette gum and abusing it, right? Because it's not very effective when it's smoked. Nicotine actually has a lot of effects on your gut and your stomach. It can make people feel really sick and really nauseous the first time. So yeah, nicotine is a highly addictive substance, and not just because of its basic ability to, basic pharmacological properties, but also because we smoke it when we use it. And as far as fearing drugs, I don't really think of them that way. So tobacco is a really great natural, what do you call it, pesticide. That's one of the things that farmers did was plant tobacco in with their corn and other crops because it kept the insects away, because it will actually kill insects. You can actually overdose on nicotine. It can kill you if you have really high concentrations. So I think drugs are occurring in nature. They are there for us to use responsibly or not. All drugs have a desirable effect as well as a side effect, and that depends on how we use them and the dose. So yeah.
So one more question, if you don't mind.
No, of course.
High fructose corn syrup.
This is, yeah. So one of the biggest questions, or one of the most fascinating questions is, to what degree are drugs special, right? So people can be addicted to gambling. People can be compulsive eaters. So the DSM includes bulimia, which is people who have bulimia are consuming food to the point that it's painful. They don't want to consume food, and like weird foods, like they might just eat, a ton of cookie dough, or so like it's not within the realm of normal behavior. And so this is a really vibrant topic in the field. Is this all one thing? Or is there something special about this? And I think one of the biggest challenges, especially for food, is that it is not biologically disadvantageous to overeat. Food is a biological imperative. Drug is not, right? And so there's some conceptual difficulties there that there's the scientific community is really trying to address, and on like the social level and the biological level. So it's not it's something that people are talking about right now. Okay. Thank you guys very much.